Okay, all right, so now they paused. Okay, all right. And we're off. Okay. So I'm so happy for you guys that you're starting a PCP chapter, because that's actually how I got to know Andrew about, I don't know how many years ago now, 4 or 5 years ago. I was an intern at Johns Hopkins in Baltimore, and I heard about Primary Care Progress, and I started a chapter, and it really transformed our campus. I feel like our campus has really taken off and embraced primary care. We have a primary care leadership track in our medical school now. We have students and residents who sit on our primary care consortium, which used to just be faculty members. And while myself and my colleagues that did the PCP, made the PCP chapter can't take credit for all of that, I really think that we added a lot to the conversation on campus about primary care. So I'm very excited for all of you. And today I'm going to be talking to you about something that's really important to me. So I am a general internist, but I'm also a fellow in geriatric medicine, which for those of you who don't know is care of people over the age of 65. And those patients tend to be some of the more complicated patients, because when you've lived that long, you've kind of had a lot of things happen to you. And that's what I really enjoy. I enjoy patients with complex medical issues. And so today I'm going to be talking to you specifically about a project called the Student Hotspotting Initiative, something that you all could do here at SLU in the future if you're excited about it. And I'm happy to take questions at any time, but I'll also leave some time for questions at the end. So feel free to interrupt me or jot down your questions for the end. So I don't have any financial disclosures, but I am totally biased about this topic. I think it's the best topic ever. I love patients with complex issues, and I think that you all should too. Don't be afraid of them. It's a wonderful learning and teaming opportunity. Forgetting my number 2. And I also wanted to give credit to the Camden Coalition. So I'm going to be talking to you a little bit about what the Camden Coalition is and who they are. But they helped with the preparation of some of these slides. So I just wanted to give them some credit for that. And then finally, although I'm mostly going to be talking about the Camden Coalition of Healthcare Providers, there are a lot of other organizations who do this work. So I just wanted to mention that to you all, and I'm happy to give you any resources or references at the end if you're interested. Okay, so how did I end up in front of you all today? How did I get to know and experience hotspotting? So when I was an intern, a first-year medical resident, the senior residents in my program ahead of me read this article. It was in the New Yorker, written by Atul Gawande. He's a pretty famous medical writer. You might have read some of his other stuff. And this is a really great article that I would recommend to all of you. It introduced the world to healthcare hotspotting and this family physician in Camden, New Jersey. His name's Jeff Brenner. So as the article explained, healthcare hotspotting actually came from the world of policing. So I am from Baltimore, and you all live in St. Louis. So I know that we have a lot of ideas about policing, but we're just going to put those to the side. And, police are a really important and expensive resource for a city. They want to use their police force well. And so when police departments thought about crime, they realized that most crime was being done by a small group of people, and that most of these crimes were occurring in geographically restricted areas. So as you can see on this map, I think I have a pointer, there are some hot spots or areas where most of the child abuse and neglect is occurring in whatever city this may be, and then hot spots of domestic violence. And so Jeff Brenner, a family physician, translated this idea to healthcare. So he said, in healthcare, we see the same pattern. There's a small group of people who tend to go to the hospital and the emergency department over and over and over again. And when he mapped them out where they live in his own hometown of Camden, New Jersey, he saw the same thing. They tend to live in these really concentrated areas or in healthcare hotspots. So that's where this word hotspotting came from. And what Dr. Brenner did is he sent out a team, not of doctors. Doctors do a lot of great things. I'm a doctor. But he sent out a team of nurses, of social workers, of behavioral health coaches. And these health professionals engaged with these healthcare hotspotters. And they had dramatic results. They reduced utilization of healthcare resources by over 50%, and more importantly, they made a big difference in these people's lives. So the residents in my program who read this article thought, well, wait a minute. In residency, we see patients over and over and over again in the hospital, the same people, and we take care of some of these people in the clinic. So wouldn't it be meaningful to pair each incoming intern, so that was me, an incoming intern, with one of these high-utilizing patients to teach the interns about what this population is like? And so that's how I came to know hotspotting. I met Mr. B. This is not actually Mr. B, just for HIPAA reasons. This is something from Google Images. But Mr. B was in his 70s, and he had a lot of chronic medical conditions. The most prominent were really bad lung disease, COPD. He required oxygen all the time, just like this gentleman. And he also had a lot of chronic pain in his joints, and a lot of chronic pain in his belly, because he had chronic pancreatitis from drinking a lot of alcohol in the years before. And as I prepared to get to know Mr. B, I was, reading through his chart, and I saw all these words like drug-seeking, manipulative, non-compliant. And I'm ashamed to say that the picture that I painted in my head of Mr. B was not very pretty. And I was really worried about that. I mean, first of all, I was only an intern. When my pager went off and I needed to order Tylenol for a headache, I kind of freaked out. I was like, oh, do I need to check the liver enzymes? And should I give him 1,000 milligrams of Tylenol or 325? And should it be every 8 hours, every 6 hours? So this seemed like kind of a big task for me. And I had never been a patient in the healthcare system. I had luckily been very healthy. And so it seemed like I didn't have much in common with him. And so how was I going to engage someone that didn't seem interested in their health and in their relationship with me? Well, part of the experience was that I did a home visit. And so if you haven't been to Baltimore before, well, the typical Baltimore row home looks just like this. And Mr. B lived in one of these typical Baltimore row homes. Again, not his actual home. But I remember pulling up to his house with my preceptor, and we knocked on the door. He answered the door with a big smile on his face. He was so friendly. He had like feet of oxygen tubing dragging behind him. And he welcomed us into his home. And when I walked in, I was kind of in shock. I looked around, and everything was clean and well furnished. There was a welcome home sign, like a hand-painted welcome home sign on the wall in the kitchen. And the whole first floor smelled like apple cinnamon potpourri. I was like, wow, this is not what I expected. So we sat down at the kitchen table. We had some iced tea. We got to know each other. And he told me about the good times. He grew up in Florida, had 4 kids and a wife. He was a carpenter. But then he also told me about the bad times. And this grown man started to develop well-up tears in his eyes as he told me about when he moved to Baltimore. And he lost his wife and 2 of his sons to suicide in his own home, all 3 of them right around the holidays. And he described for me how after that happened, he totally lost control. He started drinking heavily. He started using drugs. It was a very dark time in his life. But, he assured me, that was behind him now. He got the help that he needed. He had turned a new leaf, and he was happy and ready to invest in his health care. But every time he went to the hospital, it seemed like the healthcare system wasn't ready to invest in him. They didn't trust him, that he wasn't just drug seeking. So when I left his house that day, quite honestly, I was really ticked off. I thought, both myself and the healthcare system had painted this incomplete and inaccurate picture of him, right? He's not manipulative. He's not drug seeking. He's just misunderstood because no one had taken the time to really hear and understand his story. So Mr. B and I start on our path together as doctor and patient. And at first it was great. It was lovely, almost like this picture. But then we started to hit some bumps. So he lost his oxycodone prescription. He ran out early. He would have me paged every week asking for more medication. And my heart would sink when I would see that it was from him. Or I'd see his name on my clinic list and I'd think, oh no. I was just so tired of having that same conversation about, I'm worried about how you're using your pain medication. And he would say, I'm worried you're not giving me enough pain medication. And it was frustrating. We were just stuck. And I thought about sitting at his kitchen table and drinking iced tea, and I worried that I was becoming one of those bitter providers that wasn't really trusting him. But eventually, one fall day, I was sitting with my preceptor in the resident workroom, and we kind of laid it out, all the different red flags, all the things that had happened. And it was clear to me that I couldn't keep giving him opiate pain medications. It just wasn't safe for him anymore. So I stopped prescribing them, and about a week later, he ended up in the emergency department in withdrawal. And I walked to the emergency department, and I felt like a dog with its tail between its legs. You know, I was so ashamed. I knew that I did the right thing, but here he was. So I went into his room, and at first he didn't want to talk to me. He didn't really want to look at me. But I just sat there. I pulled the curtain. There was like the chaos, the alarms, and the pagers going off on the other side of the curtain. And in that relative silence, he actually started crying. And he said that he was addicted to pain medication again. And he wanted help. And he was hoping that I would help him. And so I did. It wasn't easy, but we got him into a methadone program. And over time, he started coming to office visits again. And we both looked forward to the office visits again. My heart didn't sink every time I saw his name. And the amazing thing was, for the first time in a long time, his number of hospital admissions went down. He started to spend more time at home than he did in the hospital. So reflecting on this experience with Mr. B, I certainly learned and grew a lot as a physician, but I also learned an awful lot about our healthcare system. First of all, I learned that we get it wrong a lot in healthcare. Healthcare is just not set up for people like Mr. B. I mean, do you really think that in a cold exam room in 15 minutes with the clinician sitting there typing on the computer that someone's going to open up about the trauma they experienced? I mean, just a couple of weeks ago, I went to my family medicine doc just for, regular once-a-year checkup, and I'm checking in, and the medical assistant takes my vitals, and she's recording them in the computer, and she goes, in the last 2 weeks, have you felt down, depressed, or hopeless? And I thought, well, I do now. I mean, so we're just really we're not set up for this kind of conversation. The other thing is that this is really hard. This is hard work, right? I mean, the relationships that we have with these patients, they are challenging. They're physically taxing, they're emotionally taxing. There's days where you're like, why am I doing this? But you know what else? Is that we can absolutely do better. We can 150% do better. And the reason that I'm so confident that we can do better is that there are a lot of people around the country who are doing better for people like Mr. B. And one of those people is Jeff Brenner, who I mentioned earlier, the guy that came up with healthcare hotspotting. So what Dr. Brenner and his organization is called the Camden Coalition of Healthcare Providers. I'm just going to be referring to it as the Camden Coalition. What they do is they have set up a whole system for people just like Mr. B. So people who are really sick, they have a lot going on in their lives, and the system is just totally failing them. This 5% of the population, I don't think my pointer shows up. I don't know if my arrow shows up. This 5% up here, like Mr. B, they go from hospital to hospital, emergency department to emergency department, and as a result, they account for 50% of the cost of healthcare in the US. And healthcare in the US is 18% of GDP. So this tiny little population is, costing an awful lot of money. And more importantly, they're not having their needs met. Yes? I'm referring to all kinds of problems. When you look at this population, it is a very heterogeneous population. There are people who are in their last years of life, and they have cancer, and they're having complications from chemo, and they're coming in and out of the hospital. There's people who are having somatization and are looking for pain medications or anxiety medications. It's a big, diverse group, and for the sake of simplifying and oversimplifying, I just lumped them all together. But great question. So the thing is, we see these patients all the time in the healthcare system, and what we often forget is that they're actually the outliers. So there's a bell-shaped curve of patients, right, representing how much they need and how much they cost. And these patients who we're seeing over and over again are 2 standard deviations from the norm. They're way on the end. They're the highest cost and the highest need patients. So hopefully I've convinced you that this is a big problem and an important one. So what has Dr. Brenner figured out to help these people? So Dr. Brenner and the Camden Coalition, their model starts first and foremost with real-time identification of the highest utilizing patients in their city. So they came up with a health information exchange. And all that is an agreement between the 3 hospitals in their city that they're going to share data. They're going to share who's in their hospital, what medical problems they had, what CT scans they got, so on and so forth. I'm not sure if you have one in St. Louis, but different cities have them. So he set up this health information exchange in Camden. And every day, his team looks at a dashboard just like this. And the dashboard tells them who's in the hospital right now, how many times have they been in the hospital recently, and then the team can kind of scan through and identify who would be appropriate for their outreach programs. While the patient is still in the hospital, the team will approach the patient and start engaging them in their programs. And once the patient leaves the hospital, they follow them home. So here's a picture of the actual Camden Coalition team in a nice lady's home. And when they engage these patients, they use a couple of different strategies. Some of these are pretty common. So how many of you have heard of motivational interviewing? A lot of people, right? So who can give me, someone yesterday gave a great definition of motivational interviewing. Can someone give a definition of motivational interviewing? Yeah. Exactly. Did everybody hear that? So what you're trying to do is, through a structured conversation with someone, get to their motivation for a change, and then help them use that motivation to actually make a change, right? So that's a pretty common strategy that many of us learn, and it's something that they use. It's an evidence-based strategy. But they also use some other really cool tools that I don't think that we do as good of a job using elsewhere in healthcare. And one of these is trauma-informed care. Has anyone ever heard of, bless you, anyone ever heard of trauma-informed care? Yeah, a couple people. So what, is anyone willing to give a definition of trauma-informed care? Okay. Mm-hmm. Exactly. That's exactly right. So trauma-informed care is just the idea that a lot of these patients have experienced some kind of trauma in their life, whether that's physical trauma, sexual trauma, emotional trauma. A lot of these patients who are, quote, high utilizers have had traumatic experiences. And that's not something that, like, you don't have a section on trauma in medical school. Like right now you're on neurology. Is the next one trauma? No, it's probably like cardiology or something. So we're just not very good at asking people about this. And since we don't ask people about it, we don't do a good job of helping them to get the help that they need. I'll give an example of this in a minute, actually. Another thing that they use is something called harm reduction. Has anyone heard of harm reduction before? So harm reduction is, sometimes it can be controversial, I guess, to say. So one of the classic examples of harm reduction is a needle exchange program. So the idea of harm reduction is that, people are going to engage in behaviors that are risky, and we cannot always get them to stop engaging in the behavior. So sometimes the best that we can do in that moment is try to reduce the risk of harm as much as we possibly can. So, for example, people who are addicted to IV drugs use needles, and they often don't have the money or the resources to get clean needles, and so they end up sharing them and spreading different bloodborne illnesses such as HIV and AIDS. And so needle exchange programs provide them with a way of getting clean needles. So they are reducing the risk of needle sharing. So that's an example of a harm reduction problem, or harm reduction strategy. But what they also use is something called accompaniment. And accompaniment is the idea that when the Camden Coalition comes in, when these care coordinators come in, they're going to be very active participants in the patient's life, but they're only going to be there for a short period of time. So they're either there for 30, 60, or 90 days. Every 30, 60, and 90 days, they kind of reevaluate how the patient is doing, because their whole goal is to get the patient to be able to take care of him or herself on their own. They're trying to empower the patient and give them the skills that they need, right? They can't hold their hand and be there every step of the way until they're 85 years old and pass away. So that is the idea of accompaniment. Any questions about any of these before I move on to some examples? So this all sounds great in theory, right? But what does it really look like? So, I'm getting ahead of myself. One thing that I wanted to mention with the accompaniment is that I said that every 30, 60, 90 days, they evaluate how the patient is doing. And one of the things that they do to do that is they create something called a hospital utilization EKG. This EKG doesn't have P waves and QRS waves. It keeps track of how many times a patient's going to the emergency department or to the hospital. So along the bottom here, you have all the different dates. And up across the y-axis, you have length of stay. So all these little tiny ticks are just emergency department visits. And then the ones that are up, that go all the way up to 14, those are different hospital stays. So what they try to do is they try to track the patient's utilization patterns before they engaged in them, and then they continue to track the utilization patterns after they engage with the patient. Yes? Yes, sir, this is one patient. I know, blows your mind, doesn't it? Could you imagine being this person? No, you're spending your entire life in the hospital, and we spend our entire lives in the hospital, It's miserable to be the patient. You see, they sit there, they're poked and prodded. So yeah, these are very complicated patients. So now we'll move on to some examples. So this is an actual patient that Jeff Brenner told me about. So we'll call her Beth. She's about 35 years old. And Beth has a problem with severe diffuse rash. Looks kind of like this. Again, not her actual rash. And she also has really bad asthma. And she has seen every single specialist you can think of, right? Pulmonology, allergy, oncology, infectious disease, blah, blah, blah. She's seen them all. But she keeps going back to the emergency department and getting admitted with these symptoms over and over and over again. So what the Camden Coalition did was they sat and they talked with her. And in talking with her, they just said, how do you spend your day? What's the typical day like for you? And she started to describe that she was bathing multiple times a day. And she was using bleach. So she was doing this because she had experienced abuse as a child. And after she had been abused, she would take a bath. And in the bathtub, she felt safe. And so the smells and the act of bathing made her feel safe. It reminded her of a time when there was safety and less chaos in her life. And so that's why she was engaging in this behavior over and over again. And how many medical specialists did it take to figure that out? 0, right? It took 0. And so what the Camden Coalition did was they helped her get the counseling that she rightfully needed and deserved to help deal with this experience. So this is an example of trauma-informed care. Something else that this looks like is a patient named Robin. Again, not a real patient, but an example of someone from the Camden Coalition. So Robin is in her 50s. She is very hard of hearing. She has diabetes, and she has very severe pain from osteoarthritis. Now, Robin has a primary care doctor, but she can't understand what he's saying. She's very embarrassed about her hearing deficit because to lose your hearing in your 50s is embarrassing, right? Normally, older people lose their hearing. So she didn't share with him that she's having a hard time hearing. So her diabetes is out of control, her pain is out of control. So the Camden Coalition arranged for a sign language interpreter to go to her visits with her. She can read sign language. And they used motivational interviewing to help her identify why she wanted to take better control of her pain and her blood sugars. And this is actual data from their work with someone whose name is not Robin, but is basically her. They were able to reduce her utilization by 73%, and her pain score, which went from 10 out of 10 to 0 out of 10. Now, how many things can you think of, medications you've learned about or tests that you've learned about, how many of those can you think of that do that? 0, right? It's not like, oh, I'll just give her an aspirin. Give her an aspirin every day and tell her to eat an apple every day, and she won't go to the hospital anymore and her pain will be better, right? We don't have anything else that's quite like this. It's really remarkable stuff. So, we're going to switch gears a little bit here and take a sip of water. What Dr. Brenner realized in doing all of this work, he has an amazing team, as you might imagine. When I meet these people, I'm like, they're like rock stars. I want their autographs, right? They're awesome. But what he realized is, well, he has this awesome team. Some of the most amazing members of his team were students. So they have a whole group of AmeriCorps volunteers who come every summer and do this work. And they were some of the most powerful members of the team. So he thought to himself, well, if these are the greatest members of our team, and health professional students need to know how to take care of these people, why not have medical students, nursing students, pharmacy students, OT, PT, so on and so forth? Why not expose all of these health profession students to this work and teach them it? And so the Student Hotspotting Project was born. So the Student Hotspotting Project is sponsored by 3 national organizations. So the Camden Coalition of Healthcare Providers that Dr. Brenner runs, Primary Care Progress with our very own Dr. Morris Singer, and the AAMC, the American Association of Medical Colleges. So this program started in 2014 with 10 schools. They actually said that they were going to accept, I think, 5 or 6 schools. But they had 25 schools apply. So they said, oh my gosh, there's so much interest. Let's do 10 schools. So they did 10 in 2014. They did 20 in 2015. And they're hoping to do 30 in 2016. And maybe in the future, SLU will be up here. Just throwing that out there. It's an idea. So what is student hotspotting? So student hotspotting occurs every year, so 2014, 2015, and it's about to start again now in 2016. It is 6 months in length. It starts in July, and it goes to January, and that's the end of the experience. Intense but awesome experience. Each institution makes a team of 6 students per team. They can have multiple teams if they want to, but each team is 6 students. The students have to come from more than one health profession school. So if you're from Hopkins like me, we only have 3 health profession schools on our campus. How lame is that? But we include all 3 health profession schools in our team. You guys have a lot of health profession students on this campus, so you could include lots of different health professions on your team. But there has to be at least 2 different health professions on your team, so it's an interprofessional experience. Supporting these students, there's a faculty advisor, one from each of the health profession schools. There can be other project advisors as well. And there's also a licensed clinical social worker, because a lot of this work requires the knowledge that our social work colleagues have. So the curriculum spans across 6 months. It's flanked on either side by 2 really awesome in-person meetings. So this is a picture of some of the students at one of the in-person meetings. That was in June, because you can see it's nice and warm. When we come back in January, everyone's wearing winter coats. But at each of these meetings, you get to meet all the other students from all across the country who are doing this work. You get to meet Dr. Brenner. You get to hear from the Camden Coalition about how they do their work. You get to hear from Dr. Morris Singer about great ways to develop your leadership and your professional skills. It's a really awesome, energizing experience. Then you go back to your home institution, and every week there is an online interactive webinar. And at each of these webinars, you learn something different. So I listed some of the things up here for you. They kind of guide you through the process, right? So your work when you go back to your home institution is to actually do the things that the Camden Coalition does. So they teach you how to identify and enroll patients. So at Johns Hopkins, what the students do is they go into the hospital, they've made friends with the case managers on the medicine floor, and they say, who are the patients who keep coming to the hospital again and again who are on your unit right now? And then the students approach the patients, they have educational material about what the program is, and they see if the patient's interested. So the Camden Coalition teaches you how to do that. And then once you have your patient, you need to engage them and do this work, right? So you learn through these webinars how to do motivational interviewing, how to use harm reduction, and how other institutions are using harm reduction. You learn about trauma-informed care. And all along the way, they're very sneaky about it. They don't sell this to you as a leadership development program. But let me tell you, after working with these students for the last 2 years, this is the most amazing leadership development program that I've seen. And you learn something that you don't get to learn in lecture halls like this, which is how to work as a team. It's pretty awesome. And there's one last layer to this. So as you're engaging with your patients, it's not easy, right? So the patients aren't like, oh, thank goodness you found me, student. Now I'll start taking care of my diabetes, right? That's not going to happen. It's really hard, right? That's why it's fun, right? Because it's hard. It's a challenge. So all along the way, you have support through case conferences. You get to present through a video chat to one of the experts at the Camden Coalition about your patient. So you say, oh, I have Mrs. Smith. You know, she's 65. She's kind of in between houses, so that's a problem for her, and she has a hard time getting to appointments, and these are her medical problems. And you have an expert there who kind of helps coach you through the situation. So it's a pretty awesome experience. So again, this all sounds great in theory, you know, great sales lady up here, but does it actually work? So here's some examples of how it works. So this is the University of Rochester team presenting at the Wrap-Up Conference in 2014. The University of Rochester team, so 6 students, identified the highest utilizer at the University of Rochester Health System. So the woman who accounted for most of the hospital, she had the most hospital visits out of anyone else and cost the most money to the healthcare system. This was a young woman who was on dialysis, but she had a lot of anxiety. And when she went to dialysis centers, she acted out at the staff because of her anxiety. That's how it manifested itself. And so she had been administratively discharged, which is the nice way of saying kicked out, banned, blacklisted, from every dialysis unit in Rochester. So she could only go to the hospital for dialysis. She would wait until she was in some kind of crisis and then go to the hospital and get dialyzed and go home. So she had over 30 admissions to the hospital in 6 months. Over 30. That doesn't sound like a nice way to spend your time, right? And so the students found out about her, and they got to know her. They learned about her anxiety, and then they advocated for her. And they got a dialysis center to take her back. And they started going to dialysis with her. They brought coloring books to kind of help calm her down. so she wouldn't act out at the staff. And if you can see here on their slide, her utilization, her number of visits goes, whew, right? Totally drops off. She had, I think, 34 visits in the 6 months before they worked with her, and then 1 after they worked with her. 1. This also looks like this. So this is not quite as dramatic, but it's from my Hopkins team, so I'm a little bit of a proud mother, and I want to brag about how awesome they are. This was a woman with sickle cell disease who developed breast cancer while we were working with her. And before the intervention, she had 21 emergency department visits and only went to the clinic 4 times. She didn't have a primary care doctor. She didn't have a kidney doctor. She didn't have all these other doctors that she needed. So the students worked with her, and they found out actually her biggest problem was she lived over the county line, which sounds like, okay, you can drive over the line. It's not like there's a big wall there, right? But if you're dependent on public transportation or subsidized transportation through your insurance, they don't cross county lines. For them, it is like the wall that Donald Trump wants to build, right? Like, no go, you can't get through. So they were able to advocate for her. And they made the couple of phone calls that other people wouldn't make for her. And they got her free transportation. And so her visits dropped, right? Almost 50%, the number of emergency department visits afterwards, and doubled the number of outpatient visits, right? She has a primary care doctor now. She's going to the sickle cell clinic now. Things are doing better. I personally cannot think of anything I do for my patients that does this, right? There's nothing that I do. And I'm not a bad doctor, at least I don't think I am. But this is really amazing. This is not stuff that we do every day. And this finally also looks like this. I have to say that being here at SLU is just like mind-boggling for me. You guys are so lucky that, first of all, you have an IPE center. Most schools don't have that. And you have lots of faculty who are really invested in having you work with other health professions. That's really unique about this place. So maybe this isn't as much of an attractive feature for you all, but look at all of the health professions that are involved in this project. It's amazing, right? I mean, health administration, we had a Master's of Health Administration student on our team last year. It was amazing what she taught all of us that we had no idea about. Medical dietetics, community health, business. It's an amazing learning and growth experience. Okay, so we're going to switch gears one more time. So I wanted to pause to see if there's any questions about the student hotspotting experience. And there'll be time again at the end for more questions. Okay, so now I've taught you a lot about hotspotting, I hope. And now I want you to try a little bit of hotspotting yourself, right here from your very own seats. So I want you to meet Michael. Michael is also an actual patient from the Camden Coalition. He is 35 years old. He is addicted to heroin. And he has these 3 problems in addition to his addiction. He doesn't have insurance. He doesn't have an identification card. He doesn't have a place to live. So Michael is coming in to see you, sits down with you. What is your first priority for him? He has all these problems. He says, Doc, I have all these problems. Where do you start? Yes. Great. 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 So we're going to learn more about him, maybe what's motivating him based on his past experiences. That's wonderful. But what if you had to make a list of like, okay, Michael, we're going to move forward together. And I think the most important thing that you do first is focusing on the ID, okay? So we got lots of votes for the ID. Any other votes? It could maybe even be something not on this. The homelessness. Homelessness is an incredibly powerful social determinant. Yes? Yeah. These are all really, really great responses and all things I would totally do. Now let me tell you what the Camden Coalition does, because when I learned this, I was just like, whoa, mind blown, oh my gosh. So what they've said is, who cares what you think is the most important? What about what Michael thinks is the most important, right? This is his life. So when you ask Michael, he says, you know, Doc, my biggest priorities are that I really, really want to get a job. I think I'd feel a lot better about myself if I had a job. And I really want to find a place to live. It's not fun being homeless. Sometimes I can sleep on a friend's couch, but sometimes I can't, and I'm under the underpass. So those were his perspectives. Now, how might you get to these perspectives? The Camden Coalition engages in something called backwards planning. And so what backwards planning is they have a number of cards, and each card has on it what one of these bullet points says. So get a job or go back to work, have medical equipment, medication, deal with my legal issues, so on and so forth. They came up with these points based on their experience of working with other high-utilizing patients. These are the issues that come up again and again and again. And if you notice, they put each of them in very patient-friendly language. So what they do is they give the patient all of these cards, and then they give them this matrix. And what they do is they have the patient put the cards in the quadrant that they feel it best fits in. So in the upper left-hand corner, so you can see across the top, it's a timeline, right? What I need to do right now, what I can put off till later. And then they can divide it into things I need to work on and things I don't really feel like I need to work on. And so starting in the upper left, you can see what the patient thinks is a crisis, what has a deadline. Oh my gosh, if I don't fill out my Medicaid form in the next 2 weeks, I'm not going to have insurance. And what is a top priority for them? In the lower right corner, you can see the things that they want to put off for later because they don't need to work on it. So this might be what the patient sees as a strength. So maybe Michael, despite being homeless, has access to a car and can drive. Then transportation might go in this bottom corner, and you can say, ooh, whoops. And you can say, great, that's a strength for you, and help kind of empower them and make them feel good about that. The other two quadrants lend themselves to having a great conversation with the patient, right? So you say that you need to work on getting an identification card, but you want to put that off until later. Can you tell me more about that? Or, you know, right now I really don't need to work on understanding my health conditions better. Why is that? Why did you put that card there? And it's a great way to get to know the patient and how they are categorizing their different health priorities. So in real life, this looks like this. There are actual physical cards and an actual physical matrix. And it's a great way to really empower the patient to feel like they have control over their life and where they're going, and to have a conversation about their priorities, your priorities, and maybe how you can align them. Okay, so now I've talked your ear off about hotspotting, and maybe some of you are excited. Maybe some of you want to learn more. The great thing is that the Camden Coalition is very willing to share. They're very generous. So they've put together 2 amazing online toolkits, and I put the websites up here for you. On these online toolkits, you can go step 1, 2, 3, 4 to start your own hotspotting initiative. Something else you can do, the deadline is actually today, but it gives you a whole year to prepare, is apply for the Student Hotspotting Initiative, right? So that's that program I was telling you about that goes from July to January. So that's something to think about. Maybe your Primary Care Progress chapter wants to do that. Yes, Andrew. No way! Breaking news. Yes, and I'm happy to answer any questions about it. I've done the program for 2 years now, and I'm kind of in love with it. So I might kind of gush about it, but I'm happy to answer any questions. So On that, I just wanted to leave you with these 2 take-home points before I let you all ask me whatever you want to ask me or say whatever you want to say. One is that these patients are all around us, whether you like it or not. When you go on the wards and when you enter residency, you are going to be taking care of these patients. Because at the rate the healthcare system's going, we're not helping them very quickly, right? So you're going to deal with these patients, and they deserve better. I think that they deserve a lot better. And it's not going to be easy, but we absolutely can do it. If a group of 6 students can take the most expensive person at the University of Rochester and bring them all the way down to 1 admission in 6 months, then there's 0 reason why all of you couldn't do the same thing here. You know, you could form multiple teams and do that for multiple people. I am sure that this problem also exists in St. Louis, and I am positive that you all are the people who can help make a difference. So, with that, I will stop talking. I will take any questions that you have. And if someone from the IPE office can show me how to pull up the survey link so that you all can take the survey, that would be great. So thank you. It's on one of his slides, I think. On his slides. I don't know if there's a second one. Any questions, comments, concerns? So this is the link. I know you all have smartphones. I see some Macs up there. So type in that URL and give whatever feedback you think that you want to get. Okay, so the brown jacket up there. So I can tell you a better answer for the Student Hotspotting Initiative, because I think since I'm not like an active participant in the Camden Coalition teams, I don't know how much time they spend. But our students, you know, it varies, right? It really depends on what the patient needs that week. So I know that there have been some weeks where altogether the students will have spent 10 hours with a patient just because he or she has so many appointments or needs help getting this and that, and it's just a busy week. Other times they'll spend only a couple hours with the patient. It really just, it varies. But in the Student Hotspotting Project, I would say the average is probably about 4 hours a week. Camden Coalition does this full time, so I'm not sure exactly how much time they spend, but my best guess is that it probably varies depending on what the patient needs that week. I saw another hand. Yeah. Yeah. I would say, this is a ballpark because I don't know the exact numbers, but I'd say that at least a third of the schools last year, it was only the second year, had multiple teams. Yeah. And so once you have a team of 6, you can have as many extra teams as you want, as long as you have the support from faculty to kind of help guide you and deal with the systems issues and stuff like that. Yeah. I think the team from, there was a school from Puerto Rico that had 2 or 3 teams. They were a really big, awesome group. Other questions? So they recommend that you're split into a group of 6. You know, if you had 2 teams at SLU and it was 12 students, you invariably would end up, you know, meeting all 12 together, and I think that that's just fine. I think they just recommend that the unit size be 6. There's actually data behind if you're doing group work, that 6 is kind of like that sweet spot where you get the most bonding and conversation. So I don't know if that's where they came up with the number, but yes. So it sounded like you asked a couple questions, so I'll try to answer them. One, no, don't be sorry, it's wonderful. I just want to make sure that I'm actually answering you. I'm not a politician. So it absolutely has changed the way I practice. So there's a patient who, Miss T, she, for years, I've been taking care of her now for 5 years, and she has like a couple of chronic medical problems, but not that many. And for reasons that escaped me for years, she kept going to the emergency department for things that like I wouldn't go to the emergency department for. She has like a leg cramp, and she would go to the emergency department. I'm not kidding. Most of her emergency department visits were for leg cramp. And I just thought, I would talk to her about her leg cramps in the office, I sent her to physical therapy, maybe she could learn some stretches for her leg cramps, and it just like baffled me for years. And then I learned about trauma-informed care. And so one day I sat down with her and I said, we've been seeing each other for like 4 years now, and I don't really know anything about what it was like for you growing up. What was your childhood like? And she told me about how she had this horribly abusive stepfather. And he used to beat her in her legs. He would whip her legs. And she wonders now if he damaged her legs, and that's why she gets leg cramps. And it was just like this aha moment, like, oh, like that's why you care so much about the leg cramps. And to be honest with you, she didn't want to see anyone or talk to anyone about it. But I think just knowing that about her transformed our relationship and transformed the way that we talk about her leg cramps now. And I haven't done the numbers, and my biased report is that it seems like she goes less. But it has absolutely changed the way I think about and approach my patients. I think the second part of your question was, have doctors, like more on a systems level, been able to do this? And the answer to that is yes and no. It's different. So there's a lot of really great innovative models. So Iora Healthcare, ChenMed, Concerta Health. I could send you an article that has a bunch of these. They all have created a healthcare model, a primary care model that incorporates all of this stuff naturally. At big academic institutions, like at Hopkins, for example, they've carved out little areas of doing it. So at Hopkins, we have something called PAPC, which stands for Priority Access Primary Care. And it's called an ambulatory ICU, which is another catchy name like hot spotting. And what they do is there's a nurse practitioner and a doctor. They have all of the most expensive patients for our Medicaid program, and they do all of the same work as the Camden Coalition for our patients at Hopkins that fall within that population. So, in my ideal world, it would be totally widespread and accepted everywhere. And I don't think we've gotten there yet, but there are some really interesting pockets of change. Other questions? Yeah. Yep. Yep. Yeah, it's a great point. So a couple of comments. One is that the Camden Coalition in their work, they've realized that there's actually kind of two buckets. There's multiple buckets, but grossly, if you take that 5% of people who are going to the hospital over and over again, you can kind of divide them in half of people that go to the emergency department a lot and people who are admitted to the hospital a lot. This is a gross oversimplification, lots of overlap. But if you broke it into those two buckets, the people that go to the ED a lot tend to be younger, tend to have more pain, tend to have more social issues. And the people who are are admitted to the hospital a lot tend to be older, have more chronic medical conditions. So they're kind of two separate groups. I think you're absolutely right about that continuity of care piece. And the unfortunate reality, this is actually one of my research interests, is that, so the typical Medicare recipient, the typical Medicare beneficiary, so people over the age of 65 all get Medicare, right? And anyone who's under 65 who has a disability gets Medicare. So those are the people we're talking about. They will see 5 different doctors at 4 different practices in 1 year. So if you go to your primary care office and you say, oh, my doctor's Dr. Smith, I have an urgent issue, I'm having these horrible stomach cramps, I need to see Dr. Smith. Oh, I'm sorry, Dr. Smith is only here on Thursday mornings. You'll see Dr. Brown. If you look at the data actually in primary care, we're not doing a very good job of continuity of care. So I know that I'm not really answering your question, I'm just kind of adding another problem, but I think that you're absolutely right. And sometimes I wonder if doctors aren't the answer, right? So maybe we shouldn't be trying so hard for continuity with a doctor because doctors are like in their current health system pulled in 25 different directions, but maybe the patients need a go-to nurse or a go-to social worker or a go-to, whatever. There's plenty of other health professionals who are more than equipped to build a relationship with these folks. So you're right, it's a problem. Maybe you'll fix it. So what do you guys think about this student hotspotting project? Something you think that you'd be interested in doing here? Silence. Cool. Yeah. Have a conversation about it. I think it's a great thing to think about. Again, totally biased opinion, but it's awesome. So, we still have a couple more minutes if there's any other questions, but I know that I stand between you and the med school prom. So I want to make sure you all have enough time to get ready, get your hair done, and, get all schnazzed up. So thank you very much for listening to me. It was great being here. Someone has a lot of makeup to put on up there, I heard. Yeah. Big day. Big day. Thank you.